Good evening, everybody. Yes, I'm Marc, Garnier, an anesthesiologist intensivist working in the operating theater and in ICU in Tenon and Saint-Antoine hospitals in Paris. I'm glad to present several algorithms dealing with the perioperative management of COVID-19 patients to our colleague out of France and to share with you our experience on the field. These algorithms came from the national French guidelines on anesthetic and perioperative management in the context of the COVID-19 pandemic. That contains about 60 recommendations that have just been published in the journal Anesthesia, Critical Care, and Pain Medicine. First, let's start with a few words about the current COVID-19 context. Everybody is aware about the COVID-19 pandemic that started at the end of 2019 in China and then spread worldwide. The pandemic reached Europe at the beginning of March 2020, first in Italy, and then in France and in nearly all the other European countries. Then the SARS-CoV-2 virus spread in the other continents, notably in America and in Southwest Asia. When looking at the geographic distribution of COVID-19 cases worldwide, we can see that SARS-CoV-2 spread all around the world. At this time, about 7 million of patients had suffered from COVID-19 with a proven positive diagnosis made by PCR. The current feeling of physicians and more generally of people from Western Europe and I guess from the United States is that the worst is behind us and we can see a huge reduction of new COVID-19 patients. However, this situation in Western countries that were among the first regions affected when the pandemic spread out of China to the rest of the world must not hide that the situation is very heterogeneous across the world and that in fact the number of new confirmed cases in the world is not decreasing and is on the contrary still increasing, with, for instance, more than 130,000 new cases 48 hours ago. Indeed, the new epicenters of the pandemic are now South America, in particular in Brazil and Chile, and Russia, where the 14-day cumulative number of reported COVID-19 cases is now exceeding 200 per 100,000 inhabitants. However, the situation in Europe is not totally under control. You can see on the figure at the bottom of the slide that since approximately 3 weeks, the number of cases is more stable than decreasing. This crude prevalence hides discrepancy between countries, as you can see in the figure on the top of the slide. Indeed, in several countries, there is no new cases for several weeks, such as in Austria, Luxembourg, or Iceland, for instance. But in other countries such as Poland, Portugal, Romania, or Sweden, there is still a stable number of new cases with a curve that looks like a plateau rather than a gradually decreasing curve. Consequently, considering the global situation in Europe as in the rest of the world, to date, caution is still advised and the recommendation and additional precaution advocated by health authorities and learned societies are still relevant, in particular in the perioperative context. I'm now going to introduce you 3 major recommendations and algorithms dealing with the perioperative management of patients in this context. First, a few words about the great interest of a preoperative regulation of patient scheduling. Indeed, in many countries, current activity in the operating theater cannot be at the same level as it was at the beginning of the year. This is due to multiple factors, such as remaining conversion of classical hospital beds into ICU beds, anesthetic drugs shortage, or a lack of health workforce once the many reinforcements that had come to help with patients' management at the peak of the epidemic had returned into their hospital of origin. And even we see some patients who had feared to come back to be operated in an hospital where COVID-19 patients are still hospitalized. Thus, the resumption of surgical activity will be gradual and spread over time. This imposes a strict regulation of the surgical activity in order to optimize both patient care and the functioning of the structure. This aims to care the patients, and in particular the patient whose surgical treatment was postponed during the peak of the pandemic, in order to avoid a loss of individual chance, but also to avoid a loss of collective chance. That is to say, with the objective of treating as many patients as possible in the best possible way at a time when we cannot yet treat everyone equally. So, For this purpose, we suggest setting up in each hospital a multidisciplinary surgical activity regulation committee, including at least one anesthesiologist, one surgeon, and one operating theater regulator. This regulatory committee will meet weekly and be in charge of making decisions on the production of a restricted operating schedule. To achieve this mission, the committee must interact with many partners and take into account notably the recommendations from the local health agency on the prioritization of intervention to be scheduled, the list of previously cancelled and postponed cases by specialty and ward, and then the evaluation on a case-by-case basis, depending on whether the patients have reached the tolerance limits of their disease, either by disease progression or by the risk of decompensation or pain. In addition, the patient rescheduling should take into account the presence of risk factors for increased susceptibility to SARS-CoV-2 infection and severity, in order to estimate their viral risk and to assess the risk-benefit balance of the surgery at the considered moment, in particular in immunocompromised or hematological patients. Then, the committee have to take into account the availability of post-operative resources, both in critical and non-critical wards, so as not to saturate hospitalization capacities. The identification of essential health professional and medical device representative by procedure is also one key point. To put into perspective with the ability of the medical staff, nurses, and more globally of all healthcare providers working in the operating theater. And finally, the committee has to take into account the state of drug stocks, while several molecules are experiencing supply shortages, the states of blood product stocks, while collection of blood from donors has considerably been impacted by the lockdown and now by the progressive deconfinement, the state of medical supply stock, while the consumption of many supplies, such as heat moisture exchange filters or closed suction system, has dramatically increased in ICU in the former weeks. And finally, the state of medical device condition and availability. To that, the committee must have close contacts with the local pharmacy, blood delivery agency, purchasing department of the hospital, and bioengineering department. At the end, the surgical program will be made each week by taking into account constraints and possible temporary restriction on this or that anesthetic drug or this or that device, leading, for instance, to give priority to surgery that can be performed under local regional anesthesia on 1 week, and those that do not require planned intraoperative transfusion on the other week. Then let's talk about the preoperative COVID-19 diagnostic strategy as recommended by our society. As mentioned in my introduction, the SARS-CoV-2 is still circulating in the population of many countries. This should be taken into account as data regarding the prognosis of patients undergoing surgery with a perioperative SARS-CoV-2 infection has recently been published. In this study from The Lancet, the perioperative mortality has reached 30 to 40% in patients older than 70 years operated from major or emergent surgery, and 15 to 20% for minor elective procedures, which is far above the usual outcome. In younger patients, 30-day mortality was up to 25% for emergency major surgery. Subgroup analysis showed that age, male sex, high hazard grade, and oncological and major surgery were particularly at risk of postoperative morbid mortality. Consequently, avoiding operating on a patient with COVID, especially in these most vulnerable subgroups, is of great importance. The first step is to determine if a patient presents clinical signs of COVID. Indeed, we believe that a preoperative screening strategy with a systematic PCR for all is not relevant. First, it can lead to overwhelm the global capacity of performing PCR if it is performed in both medical patients with clinical suspicion of COVID and in all the surgical patients before the surgery. Secondly, performing a PCR in the whole surgical population would lead to decrease the positive predictive value of the test, as the incidence of SARS-CoV-2 positivity in this whole population would be much lower than in the subgroup of symptomatic patients. To this end, Checking for symptoms is recommended during the pre-anesthetic consultation and a second time during the pre-anesthetic visit just before the surgery, and better using a standardized questionnaire. Indeed, the use of such a questionnaire increases the completeness of the symptom collection and the reproducibility of the medical examination. We propose such a questionnaire distinguishing between major and minor symptoms, designed to look for the most frequent COVID symptoms, such as fever or dry cough, and the most evocative ones, such as anosmia, without declining all the unusual symptoms that have been reported in the literature. In addition, a close contact within the last 15 days with a person with a confirmed SARS-CoV-2 infection is also sought, as it is a major risk factor for COVID. Then, in the case of high suspicion of COVID-19, defined as the presence of one major sign and or at least two minor signs, it seems reasonable to postpone the intervention for 24 to 48 hours to obtain the results of a SARS-CoV-2 PCR performed on a nasopharyngeal swab. If the PCR is positive, COVID-19 infection requires postponing the intervention until patient recovery, which is set in France for a period of at least 14 days after symptom onset, extended to at least 24 days in immunocompromised patients or patients with a severe form of COVID-19 in whom clearance of the virus may be longer. At the end of this postponement period, the patient returns to the first line of the algorithm, recollection of a nasopharyngeal swab if symptoms persist, or in the absence of symptoms in the case of surgery at risk. If the PCR is negative, and taking into account the existence of false negative results, if the clinical presentation is evocative, especially if it is reinforced by characteristic paraclinical signs such as lymphopenia, eosinopenia, or elevated C-reactive protein, it should be considered that the patient has a SARS-CoV-2 infection. And then the diagnostic probability may be reinforced, especially in the case of major surgery at risk, by either a thoracic CT scan or control of a PCR and a single sample and or serology. But in this, for serology, only if the symptom has been present for at least 7 to 10 days. If the patient presents with signs compatible with a SARS-CoV-2 infection, but that the PCR is negative, the evocative paraclinical signs are absent, the CT scan showed no sign of SARS-CoV-2 pneumonia, and the serology is negative, a differential diagnosis is then the most likely, and the intervention will be postponed until this other pathology has recovered. In a patient with a low suspicion, meaning only one minor symptom, the presence of a close contact in the past 15 days with a person with suspected or proven SARS-CoV-2 infection increases the likelihood that the patient has a SARS-CoV-2 infection. Then, his or her management becomes similar to that of a patient with a more suggestive clinical presentation. Similarly, the presence of risk factor for a severe form of COVID-19 in a post-symptomatic patient encourages further preoperative investigations to confirm or deny the diagnosis of COVID. Finally, in a completely asymptomatic patient, a distinction should be made between first, surgery with opening or exposure of the airway, such as ear, nose, throat surgery, thoracic surgery, oral surgery, etc., for which there is a significant risk of aerosolization of the virus for the operating room staff, then motivating the realization of PCR even in asymptomatic patients as long as the virus is circulating in the population. And secondly, surgery for which a SARS-CoV-2 infection could have serious postoperative consequences, thus motivating PCR testing. This surgery can probably be summed up as major surgery, like open heart surgery, major abdominal or pelvic surgery, or organ transplantation. Indeed, the frequent respiratory impact of this surgery justifies a more thorough diagnostic approach, as the risk of synergy between SARS-CoV-2 and perioperative lung injury is now highly suspected. In these two situations, this PCR will ideally be performed in the 24 hours preceding the interventions in order to have an idea of a viral coverage as close as possible to the high-risk procedure, while taking into account the time required to obtain the result in each hospital. Finally, in non-major surgery in asymptomatic patients, the surgery can be performed without any screening test. Lastly, a few reflections about the perioperative pathway in the COVID-19 context. Once the indication of surgery has been confirmed and scheduled, we strongly suggest that a dedicated COVID pathway be put in place in each facility due to the infectiousness of COVID-19 patients. This pathway must start in the surgery ward and then includes the operative theater, the recovery room, the intensive care unit if necessary, and then go back to the ward. Depending on the actual incidence of COVID at a given time in each country and region, this pathway may be declined in two different ways. In the event that the incidence of new cases remain high, this pathway must coexist with the conventional non-COVID pathway. On the contrary, if surgeries in COVID positive or highly suspected patient has become anecdotal in your hospital, the conventional pathway may be the only circuit used routinely, while the specific pathway will only be deployed in case of emergent or non-deferrable surgery in a patient with proven or suspected COVID. In this later case, the specific CAF pathway cannot be improvised and must be anticipated and carefully prepared and then field tested. Anyway, this COVID-specific pathway must include at least the four following concepts. First, security, meaning that adequate protective measures are taken to protect healthcare workers and all the other patients. Secondly, identification of this pathway, notably by visible and uniform signs warning the health worker of the presence of a COVID patient, in particular in the interventional room, in order to minimize the number of staff to the minimum required for the intervention. Thirdly, optimization of the pathway to isolate the COVID patients from others as much as possible, using notably analysis of inflow and outflow of patients. This included, for instance, the use of dedicated elevators that will be cleaned up after the patient has been transported, or a dedicated entrance into the operating room so as not to cross paths with other patients. And lastly, the identification of at least one operating room dedicated to the care of COVID patients using dedicated materials and in which specific equipments required for anesthesia of the COVID patients are always available, such as fluid-resistant lung sleeve gown, disposable head cap, video laryngoscopy devices, or closed suction system, etc. Then it only remains for me to thank you for your attention.